Hey, I'd like to be respectful of everyone's time. And again, thank you for joining today's program, Making the Most of Medicare. We're here to talk about planning for healthcare costs in retirement. My name is Kristen Kolish. I'm a financial advisor with the Mahoney Group of Raymond James. And I'm honored to be joined by a guest speaker today, Graham Kimmerer from MFS. He's the Senior Business Development Strategist, and we brought him in because he is an expert on the topic of Medicare. My team and I speak to both our participants in our retirement plan clients as well as our individuals and families about Medicare as it is part of our overall financial plan and an overall retirement plan. But there's a lot of nuances, there's a lot of details. And I am confident that this will be jam-packed with information. You'll have an opportunity to ask questions at the end, and hopefully this will be a great use of time for you. I want to start with just some opening remarks. From my perspective, from my team's perspective of 14 people, we say that we are in the business of getting people to and through retirement. And ultimately, it is all about the people that we serve and promoting your financial well-being. So in addition to bringing you this specific content, I do want to remind you about the resources that you have available to you through your employer's plan. We are committed to working with our employer clients as well as their employees to be a resource to help on retirement planning matters. We do act as a co-fiduciary to the advice that we give your employer and the retirement committee in working with them to develop and execute a prudent process so that at the end of the day, what's most important is making decisions in your best interest. And we're collectively trying to advocate for that. This is part of our quarterly webinar series. Earlier this year, we had spoken about cybersecurity and identity theft, unfortunately, a topic that is becoming more and more important. We've done financial planning fundamentals, and actually, we were a little ambitious this quarter. We attempted to put Social Security and Medicare in one webinar, and after some reflection and some planning, we decided, you know what, they're both large enough of a topic to deserve their own program. So in July, we had a Social Security program, and today here we are to talk about Medicare. We're going to wrap up the year with a behavioral finance program on the psychology of investing. Healthcare costs is not just about Medicare. It's about understanding what are the things that you need to budget for once you no longer have a paycheck? And some of these numbers are pretty daunting. Um, if for an average couple that they both reach the age of 65, it's estimated, this number used to be $250,000, but now it's up to 330,000 is the estimate of the cost of healthcare during their retirement years. And I'll just remind you that with a 65-year-old couple, the average life expectancy is that one of them would live until age 90. So you've got 25 years of funding healthcare costs, and that doesn't even include the cost of long-term care. Plus, you're tacking on the fact that inflation is a reality, and healthcare inflation has tended to be even higher than the inflation on average goods and services. So it's no surprise that half of Americans feel a little overwhelmed about this topic, which is why we thought it was so important to bring the information to you so that you can plan for it. We're living in a world where retiree medical plans are a thing of the past, right? The way our grandparents might have retired, they weren't thinking about things like this. They retired with a pension plan, they retired with healthcare benefits. They didn't have much other savings because maybe they weren't investing in a 401k, and they didn't have as long of a longevity projection. So the idea of retirement was you retired when you could no longer work. We're living in an age where the idea of retirement is, we joke that we should retire the word retirement. It's a time of reinvention. It's, what are the things that we're going to be doing for ourselves that we couldn't pursue while we had to go to work full time, right? So we want to make sure that you are physically healthy, that you are mentally healthy, and that you're financially healthy to make those dreams a reality. Before I turn it over to Graham, I'm very happy to share that we actually have an additional resource that we can offer to you as one of our clients through our corporate retirement plans. Raymond James is offering contact through an organization called ClearMatch that specializes in Medicare and offers unbiased guidance and information. So I've included here a phone number that you can call directly if you have questions about navigating Medicare. I love the timing of this program. Here we are, it's the middle of August. It's 2 months before open enrollment for Medicare, so it gives you some time to give some thought about how you, if you're if you're at the age of 65 or older or approaching, some food for thought as you think about what is most appropriate for you. And just to recap, I am part of a team. Many of you know Kevin Mahoney and Tom Small, Steve Zakarchik, and myself. We are 4 of 14 people on our team that are available to answer your questions. Our contact information is here, and please feel free to reach out if you'd like to have follow-on conversations, either about this topic or investment-related questions that you may have. This is a resource offered through your employer, and I want to make sure that you know that you can use it and you're encouraged to do so. So with that, I'm honored to pass the baton, so to speak, over to Graham, who's going to spend about 25 minutes or so giving some prepared remarks. And, hang in there. This is chock full of information. Don't feel like you need to take copious notes because as a follow-up, we will be sharing a resource guide that has a lot of this information in print. And if you do have a question, feel free to throw it in the Q&A box through Zoom. And I'll be asking those questions of Graham likely as we get towards the end of the program. My guess is you might have a question that others may have that Graham's heard before, so he probably plans to cover it. So with that, take it away.
Thank you so much, Kristen. Thank you and the whole team at the Mahoney Group for having MFS and myself be a part of this. But most importantly, thank you all for taking a little bit of time out of your days to have this conversation around Medicare. The only thing that a lot of folks will encounter in the wild when they start thinking about taking Medicare is this handbook called Medicare and You. It's provided by the government. If any of you have seen it, you know it's pretty thick. It clocks in at 128 pages and nearly 50,000 words. To give you an idea of how long that really is, a novel needs to have 50,000 words. So they basically give you a novel-length handbook for you to figure out what's in your best interest when it comes to healthcare in retirement. Medicare can be very confusing and very complex. So, with the time that we have today, what I want to do is uncomplicate that a bit for you. What we'll do to start is talk about original Medicare. This is what the government offers you. That's Parts A and Part B, what it is, costs, and is not. Then we'll talk about additional insurance that you'll likely need to consider. So we'll cover Part D plans for prescription medications, Medicare Advantage plans, which are also called Part C plans, and then Medicare supplement plans, which are also called GAP or Medigap plans. Supplement, GAP, and Medigap are used interchangeably. And then we'll wrap up with a conversation about when it is that you need to apply depending on your circumstances to make sure you get the timing right and everything, but also to avoid any unnecessary and costly lifelong penalties. But up first with Original Medicare, I just want to let you know quickly how you qualify for it because it's pretty easy and it looks and feels a lot like Social Security. You need to work and pay your Medicare taxes for 40 quarters. Now, most of the time, we tend to think of that as a 10-year work history. However, those quarters do not need to be sequential. This needs to be 40 of them all put together. That'll qualify you. If you yourself don't have those 40 quarters, that's okay. As long as you're married to someone that does, that qualifies you. Generally, you need to be age 65 or older in order to first enroll. However, there's a couple of instances where you could enroll in Medicare at a younger age, and that involves disability and specific illnesses. If you're on Social Security disability insurance for 24 consecutive months, you can then qualify in the 25th month. Or if you have end-stage renal disease, kidney disease, or ALS, more commonly called Lou Gehrig's disease, you can qualify for Medicare as soon as you're on disability. With those, no waiting period whatsoever. And Medicare has a really big network. Most doctors in the United States participate as part of the Medicare network, and the ones that don't have specialties that are not traditionally covered by Medicare, or they might be concierge doctors for celebrities and professional athletes. The first portion of Medicare is Part A, and this is usually referred to as hospital insurance, but it covers a lot more than just going into the hospital. It can cover up to 100 days in a skilled nursing care facility after a qualifying stay in the hospital, inpatient nursing care, home health care, and then hospice care as well. For nearly 2 years, Jimmy Carter was on hospice care directly through Medicare at $0 per day cost to him, not because he was a former president. That's just the kind of hospice care you get directly through Medicare. You'll notice in the parentheses, though, it says not long-term care or custodial care. And on the earlier slide that Kristen showed, it also said this is not inclusive of long-term care. Medicare will not pick up any custodial care needs. So that's if someone needs to help you do daily activities, Medicare doesn't pick that up. Or if you're considering going into a long-term care facility, Medicare may pick up some of the treatment depending on the facility, but absolutely none of the room and board. And these facilities can be very, very expensive. So you'd want to make sure you're at least budgeting appropriately, or maybe seeking other forms of insurance that can help you offset the cost of the stays in those facilities. In addition to being called hospital insurance, Part A is usually called premium free Medicare. And for almost everybody out there, that's completely true. You will not pay a month over month cost or a premium for your Part A coverage, but there is still cost for any of the treatment that you get. Most individuals experience Part A by going into the hospital at some point in their retirement. So I just want to cover what that cost would look like real quick. The first important factor to know here is that you do need to go into the hospital as an inpatient. So you're not just at the emergency room, you're not there overnight for observation. You need to be officially admitted as an inpatient. Once that happens, it sets off what's referred to as a benefit period. Benefit periods last for 60 days. If I go to the hospital on January 1st, I'm there for 2 nights, I get discharged, and I go again on February 1st, I'm inside one benefit period. But if it's January 1st, get discharged, and then I go again on August 1st, two separate benefit periods. Once that period opens, a deductible needs to be paid. This year, that amount is $1,676. Following that, if you're in the hospital for a very long period of time, Medicare requires a copayment. So the first 60 days, your explicit hospitalization costs are covered. But once you get to day 61, there's going to be a $419 per day copayment. If you're in the hospital for 91 days, you'll start using what's called your lifetime reserve days. We all have a bank of 60 of these. If they get used, they don't get replenished. While you're using them, that copay doubles. It goes up to $838 between day 91 and 150. And then if you get to day 150, you'll have to pay all the costs associated with your hospitalization. Now, I've never met anyone that wants to be in the hospital for 60, 90, let alone 150 days. And I sincerely hope that happens to absolutely none of us here, but those costs can add up. There are some horror stories about folks with rare illnesses or hard to treat diseases where they are in the hospital for extended periods of time. And regardless of the outcome, they and their families get hit with very, very large bills. But I really hope that happens to absolutely none of us.
Graham, I'm sure you're going to get
Yes.
to this at some point.
Yep.
But given the nature of our attendees, there could be folks on the call who are over the age of 65 and still working and
Yep.
perhaps covered by an employer plan. And considering that Part A is no cost, when and how should someone who has not yet retired
Mhm.
think about engaging with Medicare?
So it's going to depend, and we're going to get to some of the details on that in just a little bit towards the tail end. But depending on your circumstances, some individuals may enroll in Part A only. But if that's the case, their plan that they have through their employer is the primary payer. So it's only an extreme hospitalization. If you're there for beyond plan limits, which is usually pretty high, will that kick in? Otherwise, many individuals that are working past 65 choose not to enroll in Medicare, either Part A or Part B entirely because they have that coverage through work and you don't want to double pay for things. And we're going to get into that
Close.
double payment kind of idea next.
Great, thanks.
So the second portion of Part B, or second portion of original Medicare, is Part B, which is usually referred to as medical or doctor's insurance. So this covers outpatient services not specifically related to a hospitalization. So it covers preventative services, X-rays, CAT scans, mammograms, MRIs, things like that. Emergency room visits are covered under Part B, and that's confusing because the emergency room is going to the hospital, but that's not considered inpatient. So if I were to, get fall off my bike, I don't want to get hit by a car, but if I fall off my bike and I need to get stitches, I go to the emergency room, that's covered under Part B. But if for some reason I need to stay overnight because they want to make sure that I have a drip so I don't get an infection or something like that, that would be covered by Part A, that intrinsic hospital stay. So it can get a bit confusing, but if you just go to the hospital for the emergency room, it's Part B. And that also covers urgent care. Durable medical equipment is things like canes, walkers, wheelchairs, the hospital beds, but it can get much more specific and unique. It can be things like insulin pumps or blood test meters. What qualifies as durable medical equipment runs on for pages. And then in limited ways, Part B can cover some prescription drugs, some clinical research, and usually combined with Part A, elements of mental health care. Unlike with Part A, there are costs, month over month premiums you have to pay for Part B. You look at that middle blue column, you'll see they start at $185 and they climb to nearly $630. These are called IRMAs, and IRMA stands for Income Related Monthly Adjustment Amount. Sounds like my friendly Aunt Irma. Unfortunately, they're not. They can be very costly and they take a lot of people by surprise. Here's the surprise factor. These premiums are based off of someone's modified adjusted gross income and their tax filing status from 2 years earlier. So if I'm 65, I'm retiring, I'm enrolling in Medicare, they're looking at my earnings from when I was 63 to determine what my premium should be. So a lot of individuals find themselves starting off in higher premium brackets relative to what their actual income is going to be moving forward. And a lot of times people think that's the government, gotta pay them. You may not have to, however. Depending on your situation, if your income moving forward is much different than it was leading up to retirement and puts you below one of these brackets, you can petition Medicare to lower your premiums to the more acceptable level. Once you sign up for Part A and Part B, you're going to get a statement from Medicare that says, here's what your Part B premium is going to be. If it's higher than you believe it should be, you can then fill out a form called SSA-44. So SSA, like the Social Security Administration, -44. Sustained life event. What they call a work stoppage or reduction is the most often used one. I think we can just call that retirement. You can then make sure that your premium starts at the right base level, and that you would also need to do that for the first year and then the second year. There
And
is yeah.
no, I would just add, like, reiterate the importance of this and give you an example.
Mm,
Let's say you retired at the age of 65, and if you joined our Social Security program, you would have learned that there is an economic benefit to delay taking Social Security, 8% a year until you reach age 70. And currently, the required minimum distribution for your retirement plans are into your 70s. So
mhm.
it's not uncommon for us to see retirees actually have their income. It's almost like a U shape. During their working years, it's high. And then in the late 60s, it might decline if you're not taking Social Security and you're not yet taking meaningful distributions out of your IRA accounts. And then once you reach age 70, and then maybe age 73 or 75, when you start your RMDs, your tax bracket goes back up. So a couple notes there. For one, I would just reiterate Graham's point. It may make sense and worth your time to petition to get the lower premium in your 60s, but then also don't be surprised if this premium goes back up in your 70s when your modified adjusted income goes up.
Yeah, and I think that's kind of the second surprise factor that happens because this is always a rolling 2 year look back. So to your point, Kristen, if you take your Social Security at 70 and that could bump you up above one of these brackets, it's not going to be an immediate effect. That's going to happen when you're 72. So you kind of, it takes a lot of people again just to kind of like, oh, I wasn't expecting that. And it comes directly out of your Social Security check. So it's not even just that your premiums go up, your Social Security check goes down too. And even other activities that you do in your 70s can kind of follow you 2 years later. Downsizing a primary residence outside the excluded value. If you have a vacation or a rental property 2 years later, with investments, if there's a big capital gain distribution, that could happen. If individuals do Roth conversions, again, all of these things 2 years later will catch up, and if it could increase your Part B premiums. So I think it's imperative as to why it's you need to work with a financial professional, not just leading up to retirement, but also well throughout it so that way none of these things catch you by surprise or unaware, or you can even work and maybe plan around these altogether. I don't want you selling your house just for the fun of it, but you've been thinking about doing it and you do it more than 2 years before you enroll in Medicare. That's not going to be included and could keep you below one of these premium thresholds. So there's a lot of different tools at financial advisors' disposals and a lot of different kind of techniques and plans that you could put into place to make sure that everything matches your expectations. Aside from the Part B premiums, there's also cost for Part B. There's a low deductible, it's $257 for this year. And then following that, Medicare pays 80% of any approved cost of treatment you get, and we're on the hook for 20%. That phrase approved cost can be a bit tricky though. There's a lot of doctors out there that accept what's called assignment. Assignment means whatever the Medicare approved amount is, that's the billable amount. Some doctors don't accept assignment though. They're legally allowed to charge up to 15% more. So if you can literally pay to ask your doctors whether they accept assignment or not, so that way there's no surprise extra cost that happens once you enroll in original Medicare, particularly original Medicare plus plus a gap plan, which we're about to talk about. But there are a lot of things that Medicare does not cover. It's an enormous program. Don't get me wrong. We've just barely scratched the surface of what original Medicare does cover, but there's some routine healthcare that it does not. Routine dental, vision, and hearing, not covered. Regular physical exams is not considered a preventative service. If something happens to you outside the United States, Medicare is not going to cover that unless it's a very specific emergency on the border of Canada. So to me, it's a lot like if you're going car shopping, it's the base model. It gets you rolling down the road, but does not have all of the features that you're going to want for your healthcare and retirement. So there are other insurance plans that you're going to want to consider. The first is a Part D plan, and this is for prescription medications. You can basically think of that letter D standing for drugs. Even though this letter D is here, this is not the US government. This is offered through private independent insurers. Even if when you retire, you're on zero medications, the government requires you to have what's referred to as creditable drug coverage. If you don't, they will penalize you for each month you should have had a plan. So you'll always want to make sure that you have a plan that checks that box. But if you do have any medications, what you want to do is make sure that any of those medications aligns with what's called a plan's formulary. Formulary is just a fancy word that means a list of medications. Each plan will cover a certain amount of medications. They usually also assign these medications into one of 5 tiers. Those lesser tiers, generic, low cost medications, you'll pay less money for those, sometimes even no copays. But the higher tiers, specialty, name brand, more expensive medications, you'll shoulder more of the cost burden of those. There are IRMAs for Part D plans as well with a different formula. Premiums will vary plan by plan, formulary by formulary, and you'll want to review these plans annually. Like Krista mentioned when we're starting out here, we're about to enter that period. In the fall, from October 15th through December 7th, is what's referred to as the Medicare open enrollment period. It's a bit of a misnomer, though, because it's not all of Medicare. It's just if you are already on Medicare and have an existing Part D plan or an existing Medicare Advantage plan, which we'll be talking about next, that's when you're able to review those policies, see if anything's changed, and then make a different decision for the next year. Also, little things can happen once you have these D plans that could really, really add up. Medications could go from one tier to another, but most annoyingly, what happens is middle of the year, you go see a doctor, they assign you a new medication. That medication's not a part of your existing plan's formulary. You're either paying out-of-pocket costs for those, or you could get what's called a formulary exception, which means they'll help you pay for it for the rest of that year, but you'll need to pick a new plan for the following year. One of the biggest changes that did occur for Medicare recently is how we pay for them. And that's these two phases that you see here. It used to be a lot more complicated. It's gotten a lot more clear cut. So there's phase one, which is a deductible phase. You need to pay a certain amount before the plan steps in. The government has capped this at $590 for this year, $615 for next year. Some plans, though, might have much lower deductibles, even no deductibles, but they credit that full amount for you. Then phase two is the copayment or the coinsurance phase. If more than $2,000 is spent, and this is not just your contribution, it's the plan's, you won't have to pay any more money for covered medications, the medications that are a part of that plan's formulary. Outside of Part D plans, there's two other paths most people are going to consider. Once you're enrolled in Medicare, you can choose either the Medicare Advantage plan path or the Medicare Gap or Supplement path. I'm going to start on the left where it says Medicare Advantage or Part C. And again, even though this has that letter C, this isn't the government, this is through private independent insurers. By and large, what these plans do is basically privatize and replace Medicare. They look and feel a lot like the group-based healthcare plans you have while you're working. You need to enroll in Medicare Part A and Part B that allows you to choose a Medicare Advantage plan, but then it becomes your insurance. If you're like me and you like watching reruns of Frasier at night, this is what Jimmy J.J. Walker and Joe Namath are trying to sell you is a Medicare Advantage plan. Many of these plans are going to incorporate prescription drug coverage in there. So they have that creditable drug coverage checked for you, and they can have some other bells and whistles. Dental, vision, and sometimes hearing is pretty common. Sometimes it could be gym memberships, premium rebates, grocery stipends. If you've ever heard of the Silver Sneakers program, that's in a lot of plans. The different benefits you get vary plan by plan. The network will be different as well. They usually fall in one of two categories, either a PPO, a paid provider organization, which has both in and out of network pricing, or an HMO, a health maintenance organization, which is much more defined and local. Referrals, you might need to get referrals to see specialists. So if you want to go see a chiropractor, you may need to get that okayed from another doctor beforehand. And there's also what's called pre-authorization. Pre-authorization is a pre-approval. My doctor says I need to have knee surgery. It may not be my doctor that said you need that gets it scheduled. I may need to get that okayed by the insurance company beforehand. These are also oftentimes referred to as premium-free, low, or no-cost plans. I think that's also just a bit misleading because the Part B premiums we just talked about, including any IRMAs, you still need to pay that. Except rather than that going to the government is paying the insurer to take your healthcare off the government's table and put it onto that insurer's. You go see a doctor, you don't use your red, white, and blue Medicare card, you use the card that comes from that insurer. So again, a Medicare Advantage plan becomes your healthcare coverage, very comprehensive under one umbrella. The other path you can go down is what's called a supplement, gap, or Medigap plan. Again, those three phrases are used interchangeably. If you are upset with me because I'm about to throw more letters at you, I apologize. This is the serious alphabet soup of Medicare. If you've heard of things like G or N, those are all gap plans. As the name implies, these fill in the gaps and supplement what original Medicare does not. So they work in conjunction with Medicare. You enroll in Medicare Part A and Part B, and then you can choose one of those gap plans. There are 8 standardized letters that are out there that can all cover very different things. You do need to pay an additional premium for these. So it's Part A and Part B. There's going to be a payment for the Part B premium. Then your gap plan, you pay an additional premium for that. What do you get for that premium? It can pay the Part A deductible, could pay the Part B copayment, the overage for doctors that don't accept assignment, an international travel component. Other aspects like additional blood, if you need that while you're in the hospital, can be covered. They can really help control some back end costs for more expensive procedures or more expensive doctor's visits. It is a bit of a do it yourself method because it's A and B from the government, the gap plan. You need a separate standalone Part D plan. And if dental, vision, is hearing is important for you, you can get your own insurance on that, or some doctors might have clubs that you can join or have a cash rate that could help you save on that. The network is Medicare. So any doctor that accepts Medicare, which is again most of them, will accept your gap plan. If it's issued in New York or Connecticut, you can go see family in California, Florida. It'll all be accepted. There's rarely any referrals for specialists, and for most procedures, there's not going to be much, if any, pre-authorization or pre-approval process. To give you a sense of what costs would look like for a procedure, let's say I did need to have knee surgery. Sticker price there is about $50,000 with just traditional Medicare. So we're saying just A and B plus a D plan, which in my opinion is not going to be adequate for most people's healthcare needs. You can go see any doctor that's in the network, so that's almost every doctor, pay a Part A deductible and a Part B copayment. So it'd be about $13,000 and then cost for any medications. With an Advantage plan, I need to get that surgery pre-approved most likely. I need to stay in network, and there's going to be a deductible and a cost for that surgery. So it's a lot like the insurance that we have now. And then with a supplement plan, I can go see any doctor that's in Medicare, so almost all of them. And then depending on the plan that I chose, there's going to be no approval, pre-approval, and I may not have much, if any, to pay for that surgery. If I need to have 3 knee surgeries in 1 year, how I did that, not quite so sure. But if I did, there could be very little to possibly no cost for me. There is a catch though. In many states, you need to choose a gap plan within 6 months of first enrolling in Part B. If you're outside that 6 month window, it's not a guaranteed right of issuance. They could possibly deny you the policies or the premiums could go up. I will note if you are in Connecticut or New York, those are guaranteed right of issuance states. Regardless of anything, that's going to get issued for you. So it's a little, those states are a little bit unique. If you happen to be calling in from Minnesota, Wisconsin, or Massachusetts, those 3 states have very state specific plans that are available, but they work very, very similarly. So this leaves the last topic that we have here, which is when it is that you need to apply. There are 5 different enrollment periods that line up with Medicare. We covered that open enrollment period that we're entering into in the fall, but the two that will matter the absolute most for you is either going to be the initial enrollment period or a special enrollment period. The initial enrollment period, or the IEP, is for when you're turning 65. What we need to know is, are you planning on continuing working past 65? You have a group healthcare plan. Or if you're not working or you're not covered by your own company's plan, are you covered by a working spouse's plan? If that's the case, you do not have to enroll in Medicare at all if you don't want to. If you are covered through insurance through your workplace or your spouse's, and it's a large company, you do not have to enroll in Medicare at all. You don't even need to tell them. You'll tell them later on, but you don't need to tell them right away. You just simply don't enroll. However, if you don't have coverage through your company or your spouse, you need to enroll during your initial enrollment period. 7 month window starts 3 months before your 65th birth month and includes that month, and this extends up to 3 months afterwards. Couple of considerations here. If you work for a small employer, if it has less than 20 employees, so 19 or fewer, that coverage, no matter how good, no matter how expensive, pays secondary to Medicare. So you need to enroll during your initial enrollment period. Medicare becomes your primary insurer. That insurance pays secondary. If you're on COBRA benefits leading up to 65, or your company offers you retiree benefits up to 65, same thing. They pay second. So you would need to utilize your initial enrollment period to sign up to make sure that you're not paying what Medicare would normally pay and to avoid penalties. The other catch is if you have an HSA. And this gets a little bit to the question that you asked earlier on, Kristen, because if you're 65, even if you're planning on working to 67 or 68, why not enroll in just Part A? And I agree. It's kind of no harm, no foul. It can help out if there's a bad hospitalization. However, if you are working and you're actively contributing to a health savings account, you're then in violation of a whole bunch of IRS rules around high deductible healthcare plans if you enroll in Part A. You lose the tax deductible nature of those additional contributions, and there can be later tax penalties as well. I generally try to limit my exposure to the IRS to just once per year. So if I was planning on working past 65, I'm paying into my HSA. I don't want to enroll. If I'm not paying into an HSA or I think I have enough in there and I want to stop, I totally recommend signing up for Part A. There's no reason not to.
And if I could just interject there,
Yeah, please do.
HSA is really a very powerful investing and in saving vehicle. The s- health savings account, it really has, we talk about it as getting coupled with a high deductible plan. But we're talking about this more and more. It really should be positioned, if marketing was involved, as a low premium plan, right? Because if you're, and this is aside from Medicare, this is just talking about health plans in general, low premium, higher deductible, you could make a tax advantage contribution to this plan. The money can be invested. So here's my soapbox for literally 15 seconds. If you
Please.
do have an HSA, and you have dollars in it and it's sitting in cash, you should reevaluate. It's really an account, the only type of vehicle in the United States that we call triple taxed advantage, meaning that your contributions are tax advantage, it grows tax advantage, and if you take it out for a qualifying medical expense, you don't pay taxes on it. So literally, you can save it, invest it, let it grow. And there's no statute of limitations on distributions, meaning, you had knee surgery in 2025, you could let that money sit there and invest for 10 years and pay yourself back in 10 years. So really, the HSA, we're talking about HSAs in the same conversation as 401ks lately, because it's through the lens of where your next dollar should go and how do you think about funding your collective expenses in retirement. So there's that piece. The other point I wanted to make here as well is that Medicare, unlike your employer-sponsored plan where there is familial or family coverage, there's really no family coverage here, right, Graham? It's like you need to be the age
Yes.
65.
Yep.
So it's, if you are married and your spouse is of a different age than you, if they're younger than you may be eligible for Medicare, but they may not be. So there are other nuanced situations here that you
Yes.
some extra
Yeah,
thought.
and I'll say that if just as kind of a spur on that, if you're planning or thinking about retiring prior to 65, there's a couple of different paths you can go down. If your spouse is working, you can certainly join their group healthcare plan. You can pursue something with the open market or the ACA, or you could be on Cobra benefits. But Cobra benefits was designed to be a bridge to things. So if you retire at 60, they're only going to last between 18 to 36 months at the absolute top end, depending on the qualifying event. So Cobra benefits were only ever designed to be a bridge to something else, not your ultimate answer for your insurance. So if you're planning on retiring early, whatever insurance you have leading up to 65, you may then still have to enroll in Medicare at that point, unless of course you're covered by a working spouse, companies bigger than 20 people. If you did or you are planning on working past 65, or you're past 65, but you were covered by a working spouse, regardless of their age, then you're going to enter into a special enrollment period when that's wrapping up. So you can do this while you still have that insurance. About 2 months out is as far as you need to go. Once you lose that coverage or you retire, whichever happens first, and then up to 8 months afterwards. I'm not a big fan of that up to 8 months afterwards unless it was a surprise event and you want to figure out your next move. Do you want to go back to work at a different company? What's your plan? Because if something were to happen, you didn't have proper coverage, it could be a lot of money out of pocket for you. So as long as you know what your plan is, you can do this in advance or once you lose that coverage or you retire. Two other catches here. The first still involves that HSA that we just talked about. And I don't want any of the negative things you're hearing about HSAs when it comes to signing up for Medicare to discourage you from them because they are incredibly valuable tools. But for whatever reason, if you're using the special enrollment period when you're applying for Part A, they backdate that by 6 months. So if I'm 67, I enroll in February, they're backdating my Part A coverage into the prior year, which means I probably accidentally overfunded my HSA. Not the end of the world, you just have to pay a little bit more back to the IRS, but you'd want to stop your contributions moving forward. But if you know when you're going to apply and you know it's going to be that 6 month backlook, you can work with the work with the benefits group that provides the HSA to just fund up until the allowable limit or the allowable month. The other catch, and I hope because you're part of this conversation today and you know Kristen and the Mahoney Group, you won't ever have to worry about this. If you should have been on Part B, but you weren't at when you should have been, for each full 12-month period you should have been, they attach a 10% penalty. They call it a surcharge, but it's a 10% penalty that gets added onto your Part B premium. So let's just say I thought my company had 22 people. Turns out there's only 18, and I waited 2 additional years. That's an extra 20% that gets added onto my Part B premium each month for the rest of my life. There's no way for me to appeal that. I'm going to be pausing here in about 45 seconds to hand this back over to Kristen. But my ask of you is to start this conversation early. Not just when you're about to turn 65 or retire. We want to make sure you're having a conversation with your family, with financial professionals, to make sure you have an understanding of what your game plan is going to be. I probably said the word cost 40 times in 30 minutes. Like Kristen said, the cost of healthcare is rising faster than average inflation. We want to make sure this is part and parcel of your financial plan. And you may need to work with some licensed specialists, folks like Kristen mentioned early on with Clear Choice, or if you have any friends or family that have gone through the process and they work with other agents, they become part of your team. They're able to help you do those reviews each year and make sure that your insurance is aligning with you. Each state also currently has organizations called SHIPs, SHIP. These are state-based organizations that can help you understand the landscape. They're just not able to sell you anything because they're not licensed agents, but they can also be good resources as well. So again, I'm going to pause here. I'm going to take another sip of water. I'm going to hand this back over to Kristen, but I'm more than happy to stick around.
Thank you so much, Graham. And I hope you do because we do have some questions in the queue here. If you do have questions and you haven't yet added them to the Q&A box through Zoom, please feel free to do so at that time. Um, why don't we start with the question that's kind of big picture?
Mhm.
Medicare, Social Security, uh, the federal government budget, like these phrases all get thrown
Yeah.
around. What are you hearing or what are your thoughts in terms of, what we might anticipate in terms of
Yeah.
change going forward?
So there's been no fundamental change to Medicare for right now. The big legislation that happened in July did not change Medicare. There were some changes to Medicaid, but not Medicare. It literally takes an act of Congress to change both Social Security and Medicare. So there's been nothing fundamental to Medicare currently this year. Some things that I think will happen is more about the other insurance that we just talked about, those Medicare Advantage plans, D plans. Medicare Advantage plans have become very, very popular over the last 10 years. A lot of different companies are competing for, I'm not going to say a small group of people, but a very defined set. So I think what we're going to see is the competitive nature of Advantage plans. I think we'll see less offered in a given area. They'll be kind of condensed a little bit. I think we'll see a shrinking of benefits, or like it'll be at least a little bit more streamlined in terms of what the benefits that are offered are outside the regular scope of what they need to cover. I also think that healthcare is getting more expensive, and Medicare on its own rivals defense spending every year in terms of its actual cost. So I think down the line, this is not going to be an immediate impact, but I think those no additional premium advantage plans, I think they're going to go away eventually. But I don't think the premiums are going to get very big. I think we're talking an extra 10, 15, $20, whatever it may be. And I think Part D plans, medications are also very expensive. And because of that $2,000 cap before they just need to be covered, I'm expecting the premiums on Part D plans to go up as well. So again, I don't want to scare anybody because I think this is again this can be completely planned for, but I do think that the enticement of free or cheap additional insurance isn't going to be as prevalent moving forward.
Mm. Has the age always been 65?
It has literally since they put this into practice. When Medicare came out in 1965, it's age 65.
Can
So
you
that's
understand why it's gotten so expensive for the
yeah,
federal
yeah.
government, right? Like
I mean,
it's,
interestingly, if you ever are in jeopardy and this question pops up, um, the average age that someone passed away in 1965 was 65 and 8 months. So they were only expecting people at that point to live 8 months. Obviously, our life expectancies have gotten a lot longer, which is good for all of us.
yeah, that's great context. And I know Social Security is the same way. So the original intent of these programs was to act as a backstop, as insurance, if you live past our life
Mhm.
expectancy. Here, as it stands today, American workers are incorporating Social Security and Medicare as part of their retirement plan. So fundamentally, it's just
Yeah.
drastically different than what the original intent was for these programs. Um, we do have a question about travel
Hmm.
outside of the United States coverage, but then also if you're splitting time in the
Hmm.
US and outside the US, maybe six months here, 6 months someplace else, but that you've had your whole working career in the United States. Can you talk through the plan
Yeah,
considerations there?
absolutely. So if you're retiring early, and living outside the United States in some capacity, definitely sign up in advance of 65. So utilize that. I mean, you have that full 7 month window. I'm a bigger fan of using the earlier months because it kicks in the first day of the month that you turn 65. So definitely utilize that initial enrollment period. And then with the additional insurance that you're looking to consider, whether that's an Advantage plan or a Gap plan, check the policy information. Gap plans do have some of them will have international travel elements to it, but they're more designed for vacation
Hmm.
versus kind of splitting time in terms of living.
Hmm.
Medicare Advantage plan is very similar. It's like if you're going to be in Europe for 2 weeks, they'll help pay, but not necessarily if you're living there for months on end. So there's some Advantage plans you can kind of bolt on other insurance with it. Also, there's a lot of different travel insurance that you could get. So you may just want to consider other insurance that could help pay for the cost of care if you're planning on living abroad or splitting time in kind of outside the United States.
Great. And in terms of just one last question that we've got here, um, how does this play into like taking Social Security benefits? Like, are any of the programs related?
They very much are. I mean, Medicare was born out of an addition to the amendment that created Social Security. So they are very much related programs. Um, but they can be two very different decisions. When
Hmm.
you sign up for Medicare and when you take Social Security or vice versa can be very different. If you do enroll in Social Security prior to 65, they will automatically start the process of enrolling you into Medicare. So
Hmm.
let's just say, as an example, I'm 63. I've retired. I've enrolled in Social Security. I'm covered under insurance through a working spouse. I may not want Part B to kick in when I'm 65 because I already have insurance. So I would need to let Social Security and Medicare know I don't want that to happen. So basically, when you're 65, it'll automatically happen. You need to fill out some paperwork. You want to get technical, it's CMS Form 1763. But we can always find that paperwork for you. You then need to tell Social Security and Medicare, I don't want Medicare because of this reason, which is I have creditable insurance outside of it. Um, if again, if you just Part A is fine there, but Part B, you don't want to be paying double for insurance that you wouldn't actually be using. So they are very much interrelated programs. If you're signing up for Social Security, it's going to automatically trigger Medicare for you when you're 65. And the
Hmm.
same thing, if you're 67 and you sign up for Social Security, it'll start you because you're past 65 into Medicare, and you may not necessarily want that. So you need to let them know in that case, I don't want Medicare.
Right.
Um, and you will see the Part B premiums automatically deducted from your Social Security checks. So that's going to come out of sight, out of mind. Otherwise, you're paying it like a bill. You can also have your Part D premiums, and if your Advantage plan has a premium, get deducted from Social Security. Gap plan premiums cannot be. They always need to be paid out of pocket. And just as a side note on that, HSAs cannot be used for gap plan premiums. That's not considered a qualified medical expense, but any other premiums they could be used for. So
Very.
longer answer for a shorter question, but I want to make sure I gave all the context.
No, lots of great information. And at the end of the day, while a program like this is very informative, and I really appreciate you collaborating to help us support our participants in this way, it's very much an individual decision, right? Like, and
Yeah.
it's unique circumstances of you and your family. So it does require some thought, some planning, some discussion. I love your slide on communication and thinking through what does your retirement plan look like? And then how does your medical plan meet what you want to have in retirement? So So to that end, we're going to close the program. I will be sending out an email with the information that I promised. I'll also send the email with the information to for Clear Match if you'd like to have a conversation to talk through some of your options. If you'd like to have a conversation about how this fits into your overall financial plan, please reach out to myself and my team. And with that, I hope you all enjoy the rest of your summer. And I truly hope that you found this helpful. Graham, I know I did. So thank you very much.
You're very welcome. Thanks so much, Kristen. Take care, everyone.
Take care.